Respected Chairperson, and actually thank you the organizers to give me a chance here to be along with you. I know that I am actually with the most terrific chairperson here. And actually coronary perforation is actually, the incidence is not small. It ranges from 0.1 to 0.6%, and the mortality ranges from 7 to 12% in various studies. Classifications are type 1, 2, 3, and 3C. One is a trajectory extending outside the lumen only, and in the absence of linear staining, angiographically suggestive of dissection. The type 2 is a pericardial or a myocardial blast without a more than 1 millimeter exit hole, and 3 is actually the contrast streaming out, and 3C is actually extending to the cavity. The adventitial contrast staining is a class 1, and the prognosis is generally good. They do very well. This will be the type 1. Actually, this you have a small staining down. That is actually the type 1. The type 2 is actually the contained perforation, may occur with any modality, usually stable in cath lab, but may progress to free-flowing perforation. This will be a type 2 perforation. Type 3, actually the class 3 perforation, free-flowing, may occur with any modality, but most common with ablative techniques, may progress rapidly to tamponade. This will be one of the common type 3 perforation. The mechanism of perforation is actually a type B2 or C lesions, coronary occlusion, rotablator, and some earlier data showing IVUS guided procedures. But you can see that it is a mainly complex interventional leads to perforation, not simple perforation. Causes of the coronary perforations are devices, guide wires, and catheters. Devices mainly atherectomy devices and balloons and stents. Devices is oversizing is one common cause, cuts in minimally diseased areas, cuts in angulated segments, and wire bias. Basically, in a rotablator, people may cut on the simple lesion. Actually, the wire will assume a lowest energy configuration. This may lead on to eccentric placement, and it can lead on to perforation. Balloon rupture is actually related to excessive pressure in the treating a rigid calcified lesion. It can occur at a low pressure with a pinhole rupture or caused by a spicule of calcium. It can be an excess pressure in the balloon or can be a pinhole rupture. Balloon oversizing, another cause of it may usually comes with stenting. A high pressure inflation as well as balloon artery ratio is more than 1.2 are the most common cause of perforation with stenting. Know your balloon. Remember, a semi-compliant balloon grows significantly at high pressure and can go into perforation. Chronic total occlusion, actually, the stiff guide wires can lead on to perforation. Confirm intraluminal wire position before inflating the balloon. And a small wire perforation, vessel perforation, we may not always see that. It is usually caused by the polymer coated wires, and keep the wire actually probably in the larger branch, should not be in a small branch, and be careful with the polymer tip wire in glycoprotein 2B3A. Usually, this perforation, what it will cause? It can cause death even and tamponade, mainly with the type 3 perforation. Tamponade is a very, very bad news. Basically, it leads on to death in 7 to 17%, and mortal incidence is nearly 0.6%. All the data telling that even though tamponade is death, moreover death, it can even lead on to cardiogenic shock and MI in patients. Some of the cases I will show you. This is an RCA significant disease. Put a Galio wire, put a stent, simple, a Galio wire, balloon inflation done, stenting done. See, you can see a perforation down. A simple workhorse wire, non-polymer coated wire, done by a good operator. Tight lesion would have taken the wire to a small branch. What to do? The best treatment is a watchful expectancy, echo and partial reversal of the heparin. Prepare for a cardiocentesis. It landed in that. This is actually a case 2 is a chronic stable angina, treadmill positive, double vessel disease. You can see a double vessel disease, an angulator vessel. No wires going, 2 wires with balloon inflation, very difficulty. 2 into 2.29, stent is put, happy. Could do stenting circumflex after a lot of struggle. Another vessel is also stented, hypertension after 4 hours. Ended in a tamponade, but distal wire perforation, which was totally missed because of the multiple wire manipulation to get the 2 stents down. This another case, LED diagonal circumflex disease, you can see. Simple wire actually provided circumflex and D1 and PTC. The filter of wire is, the wire actually taking a curve like that, and we are wire taking a curve after closing and no flow distally. What to do? Wire looks okay. With the wire looks okay, what I did is actually a balloon inflation of 2 into 9 millimeter balloon. Flow came, one more dilatation, after that no flow. When no flow, I don't want to put a stent down. Wire removed, severe chest pain with ST elevation. What to do? Put another wire. The wire went, wire in the diagonal, but you can see a perforation there. What next? Removing the wire, put a stent there 2 into 37, but no pain, but expect this complication. After 2 hours or 1 hour, the patient will have a cardiac tamponade. Balloon inflation for 10 minutes. Nothing happened. I thought it's a contained perforation. Shifted the patient. After 3 hours, same thing happened. Check angiogram done. Next day. Perfect, other vessel stenting done. This another case. A lesion in the diagonal. 2 Galio wires, simple 2 into 10 balloon. Put 1 stent, 2 long stent I want to put. Alarm. Balloon inflation 5 minutes, angiogram became better, patient stabilized, but with a pigtail in the pericardium. Check angio after 3 days like this. This another case, I'm showing only complications, but think that I produce only complications. Post-MI, 1.5. It's actually a long, diagonal was very big. I put a stent 3 into 40. This is the situation. So the prolonged balloon inflation is one choice. I can put an echo evaluation, pericardial stent is another option. What I did is actually I put another stent down, a 2.25 into 36 stent for a prolonged inflation for nearly 15 minutes. Completely sealed off, and the patient became all right. With all these cases, actually I escaped, and the patient escaped, I escaped, perforation. Another one is a 64-year-old gentleman, diabetes, hypertensive, chest pain for 2 years, treadmill strongly positive, LED normal, RCA totally occluded. Wire crossed, angioplasty done outside. The wire was crossed, but it was in the subintima. Even the smallest balloon not crossed. Change of the catheter to Amplats did not help in that hospital. They tried a tonus, it was not successful. Mother and child catheter was tried, no use. Decided to top, and then advised medical management. In that bargain, actually, they put a stent in the proximal part. This was the angiogram. Patient came to me after 2 weeks. By seeing that the PD and PL were good branches, filling retrograde from the left side, retrograde technique possible, but an antegrade injection shows ostial RCA 99% lesion, mid RCA lesion has microchannels, lesion severely fibrotic or calcified, antegrade technique is the choice. I decided to take a wire, is a full FC with the balloon, not crossed. Then I took a Miracle 6, which is also not crossed, but Congress Pro 12 crossed. But I knew that they tried all the methods. So I took a Corsair here. The Corsair went down easily. Wire in the PDA. I was happy. Wire is actually, the wire movement, you just see the wire movement was not good. But I put a stent. Action, correct or not, I don't know. Patient was actually, I put one stent in the proximal part to be put. Patient getting some pain, perforation distally. To tackle the perforation first or the stent in the osteoproximal RCA. Previous stent in the proximal part, confused stents. I put one more stent. I just put a 2 into 15 millimeter balloon for 3 minutes, 5 minutes, 7 minutes. Nothing happened. Thrombus in the RCA, cardiac tamponade, pericardiocentesis, small particles, some particles I used, action in vein. Not to try and repeat a PTCA within 6 weeks was a message for me, myself. An initial dissection can worsen with the wire down. Exchange of the Congress Pro 12 with a floppy wire was a must, which I did not do, especially when the Corsair was there. It was easy to put a simple wire down. Overconfidence was not good. Should have done some more conservative for the perforation healing. Actually, I just lost that patient. Should be watchful about the distal wire, even if it is a non-polymer coated wire. Prolonged balloon dilatation and the stent with the balloon may be useful. Be prepared for a problem even sometime after the intervention. We can lose patients even after excellent care. So the type 1 perforation management is watchful waiting. Type 2, basically hydrophilic OCTOY is produced. Embolization is one treatment. Reverse anticoagulation is to be done. Type 3, reverse anticoagulation, prolonged balloon inflation, cardiac tamponade, to watch for echo, pericardial synthesis, pigtail should be ready, inotropes, access the left femoral catheter for the second guiding catheter. Surgery is the last choice. Treatment, contained perforation, balloon inflation. If the wire is distal and producing perforation, you have to go with the embolization or consult possibly to exclude the ruptured branch with the PTFE stent. If it is possible, you have a 2.5 or 3 or 3.5. Free flow, possibilities are balloon inflation, PTFE stent and PTFE stent. There are a lot of stents available. Joe stent has a maximum study available. You can use second catheter to the PTFE stent down. A distal wire perforation, the treatment is delayed presentation, reversal of anticoagulation, injection of thrombin, microcoils, coil embolization, adipose tissue, bioglue, polyvinyl alcohol, autologous blood, coils and particles for embolization. It's a lot available. Surgery, data telling it is not so good. Nearly 18 to 38% death rate after surgery also. So surgery is not a definite solution to the patients. Final thought, avoid the problem is the best thing. Recognize if it occurs early. Monitor fastidiously. Drain tamponade early. Employ niche products. Care with glycoprotein 2B3A. Coronary perforation take-home points, they are going to happen if you are a very good interventional cardiologist or if you wanted to do some complex interventions. Case planning is essential and the enemy of good is better. Balloon inflation is life-saving and gives you time to think. Know the equipment in your lab. Always look to the distal vessels at the final angiogram and always prepare for the worst, even for the best treatment given by you. Thank you.